Greetings. Welcome to Complex Degenerative Pain Syndrome Part 3. In the previous sessions, we have discussed on management, which is both invasive as well as lead management. And we have gone through graded motor imagery. The first and second step of graded motor imagery included left and right discrimination and explicit motor imagery. And in third step, we will be going through mirror therapy. And mirror therapy is the best modality which we can use in case if a person is having severe pain. So now mirror therapy is as follows. And mirror therapy is based on visual stimulation. In this therapy, a mirror is placed in the mid-sagittal plane, thus reflecting the non-affected side of the patient as it is affected. People will be visualizing their normal side as an affected side when they are seeing in a mirror. During this practice, short exercising little movement is used. And in case if a person gets severe pain when doing this activity, it has to be made into simple activities. The process involves accommodating and adapting, ultimately luring brain into an illusion. So in this picture we can see there is a mirror and an affected has been placed in the mirror and the normal hand is outside the mirror. And the person is doing activities with the right side, which is the normal side. Ultimately it gives an illusion saying that the affected side is moving, ultimately reducing in pain relief. So the first level involved moving the limb outside the mirror therapy. So only the hand which is normal will be moved in the first phase, and further progression of moving the limb inside the mirror at the baseline is going to happen, and ultimately then both mirrors will be moved simultaneously at the same time. And in this particular step, mirror therapy has to be synchronized with both left as well as right limb. Both have to move at the same time. Any unsynchronous movements of both hands will cause severe pain for the patient. Let us see how to do mirror therapy in practice. So now there is a mirror placed in mid-sagittal plane, and now both hands have been placed on both sides. Taking this hand as normal and opposite as an abnormal. So now there is a reflection in the mirror saying that this hand is the left hand. So now we will be asking a person to do general movement, which is going to be making a fist or small simple activities. If any of the activities is causing severe pain for the person, he will be doing with a minimal movements. Now I am trying to use simple movements which will go to the next movements. So now I am asking her to raise her left little finger up. Okay. Now I will be asking her to pinch with her index and thumb. So when she is doing, she has to concentrate and she has to look on the mirror. So this is the perceptual area where she is going to see the normal hand as an affected hand. So the mirror image is going to create some impression saying that she is moving the hand which is causing severe pain. So after this I will be asking her to make a fist. Please make a fist. Okay. Now the repetition is very important. When in order to have cortical reorganization, one or two types of repetition is not going to work out. We have to go on giving 15 minutes of continuous repetition for that hand, such that her brain is going to think that the hand which is affected is really moving. So please look into the mirror and try making a fist and try doing 10 to 15 repetitions. Okay, this is one activity where we can encourage them doing. So now the mirror image is going to mimic saying and it is showing that her right hand is moving, whereas actually the right hand is not moving at all. Okay, now try making wrist extension and wrist flexion. So now in the initial phase where pain is very severe, we are using the normal hand for doing the activity. Now try doing supination and rotation. So all activities include wrist, fingers can be used in doing this. So once the pain has come down, we will gradually progress to the next phase. Now initially what we will be doing is, we will be doing, she will be doing the activities which is making tip of your index to tip of your thumb, and she will be trying to do the same on the opposite side. But when doing this, she will be looking only into the mirror. Okay. Now try making a fist as much as possible with both hands. And after she gets out of this particular phase, we will be going into the second phase. So the third phase we will concentrate more on activities which is going to be synchronous on both sides. So now during this she can look into the center, she has to visualize both hands. Now she has to do this both activities at the same time. Now try making the fist with both hands. So this is the activity we are supposed to do. And when it comes to this, there is something called as a closed box and open box. Whereas in this we have used an open mirror. If there is any availability of a closed mirror, we can use that also. Where the whole box is going to close the affected hand. Maybe only one hand is available. So this is mirror therapy. And when doing mirror therapy, we have to use some guidelines. So the dosage of graded motor imagery is very important in this. So usually some studies have shown that 5 minutes or 10 minutes of therapy which we are giving has no effect in cortical reorganization. So ultimately there are some studies which have given proper guidelines that we can use to have cortical reorganization. And a study conducted by Kachuka et al. 2009 have showed that 4 weeks of graded motor imagery 7 days a week and that to 5 times of 30-minute session have an effect on pain and disability. Means in this study they have showed that 5 into 30 is 150 minutes is the time which a person has to be given per day. 7 days a week for 4 weeks to have their pain and disability reduced. There is one more study done by Mosley 2006 suggested that 12 weeks of GMI graded motor imagery 6 days a week for 50-minute session 5 times a day is found to be effective. So when considering this dosage, there will be some issues that we are going to encounter when we are trying to give graded motor imagery, and there are so many challenges which we'll face when we give graded motor imagery, because people in India situation will have low education status and other activities, and it is difficult to understand. So whatever we are trying to explain to any patient saying that this is the imagery, you have to imagine left or right, or you have to use imagery process of that particular activity, it becomes very hard for the person to explain or the person to understand also. So understanding of your patient is going to be one of the difficult tasks which you have to explain. And it doesn't come in 1 or 2 days, it requires a lot of practice. Means people will have to have a lot of patience when they are trying to use graded motor imagery. And the third thing is, in usual setup in our daily life, people usually will have sometimes left and right discrimination. So making them understand what is left side and what is right side will become a difficult task. And that too when people with CRPS where they have lateral recognition which is very low, and on these two comparison will become very difficult for them to understand. And when it comes to quality of evidence in graded motor imagery, there is a very low quality evidence done, and particularly RCTs in treating people with CRPS. But when it comes to treating pain, the first line of modality we can use is graded motor imagery. It is safe to use. We will be using the normal hand in doing the activities, whereas the affected hand is going to be at rest. And in case if it is used properly, it is going to be a good choice of modality for managing pain. At the same time, if used wrong, this will start excruciating pain for the patient, because it will start using engrams of brain and ultimately firing the opposite side neuron to cause severe pain. When it comes to next modality or next therapy of choice, virtual body swapping. So virtual body swapping is nothing but it's a virtual software where it is like virtual reality. We are going to shift a person's program into another, and they are going to see in a computer generated software, and this is going to generate and say that they have left and right, where they are going to do activities with both these two. It is equal to graded motor imagery, but whereas software will be used. But when it comes to using virtual body swapping, we need a high-tech equipment in this particular swapping region, and where we currently lacking. And tactile localization is discrimination technique which is encouraging patient to concentrate on a delivered stimulus. In this, people will be using closed eyes, and we'll ask the person to close their eyes, and we'll touch the area on both sides simultaneously at the same time. And they have to recognize which area we have touched and which area we are trying to use tactile acuity. And this is in turn increases your patient concentration and ultimately reduces pain by making them realize are aware of their body parts. And minimizing body perception disturbance, and CRPS exhibit perception deficits. In order to move the affected limb, people frequently comment that there is a need to consciously focus their mental and visual attention to the limb, often described as not belonging to me. In this particular minimizing disturbances, we will be using software to reduce their body perception and to improve their body activity more. So there is one more activity which we can use. It is almost to reduce pain. This is called as Prism Glass. So there is a 20-degree angulated glass which has been kept in spectacles and goggles. They'll be using only one-sided vision, which they'll close one eye. Only one eye is going to be open, and this causes something called as a wedge or a visual distortion. The whole area is going to get distorted and towards the affected side. And ultimately people will see their affected side, and they will be asking them to do the task which is going to be the same. And moving the unaffected limb will cause a perfect perception of moving the affected side. It is like your mirror therapy itself, but whereas the equipment is going to be very minimal, it is going to be self-generated. They can use a small spectacle. And use of 20-degree deviation prism glass for 2 weeks have caused alleviating of pain and improved function in patients with CRPS. And this has to be done continuously. 1 or 2 sessions is not going to help. And this is the picture of people using prism image. In the first picture, there is a before prism distortion, and second picture it is after prism distortion. There will be a distortion of vision, and it is going to bring lateral vision to your patient. Laterality is going to be more stressed in this particular theory. When it comes to other interventions, manual lymphatic drainage has found to be very low quality evidence, and the studies have found that in case if people with CRPS, if we start directly with effleurage or manual drainage techniques, it will cause severe pain for them by tactile localization or stimulation. And I've told you it is physical therapy or rehabilitation and occupational therapy. Now there is another therapies that has to be given to your patient apart from these two, that are psychological therapies. I told you when person is having severe pain, they will be having issues with psychology also, or sometimes psychological aspects will cause severe CRPS for the patient. So now when it comes to psychological therapies, cognitive behavioral therapy, cognitive functional therapy are found to be effective, and counseling of the person regarding the condition and operant condition has to be taught to the patient, and patient education relaxation technique is going to be the best line of education methods, where we are going to teach the patient what is the condition and what he has to do when there is a pain. At the same time, most of the people will have a lot of stress, they don't get relaxation of their affected hand. We have to teach them certain relaxation techniques, how to use that particular technique to reduce stress as well as reduced pain in the particular area. When it comes to cognitive behavioral therapy, there are steps that has to be followed when we are trying to give cognitive behavioral therapy. And why cognitive behavioral therapy is it identifies thoughts and behaviors of any patient, and it is going to channel them in a right way. When it comes to step 1, you have to identify patient thoughts, their feelings and their behaviors. And in step 2, understanding the links between thoughts, feelings and behavior. For example, people with severe pain, they will have a thought saying that if I move my limb, I'll have severe pain. That is going to be their thoughts. We have to give them a promise, or we have to give them proper advice saying that it is not going to be the same. And step 3 includes making changes. Whatever behavioral pattern we need to change, that has to be changed. And step 4 includes changes of their thoughts. Whatever thoughts they have, it has to be changed. And step 5 is challenging our thoughts. Whatever thoughts we have, for example, if I move my limb, my thought is going to be I may get pain. So in case if they are not really getting pain while moving the limb, so that there is a challenge that they are going to do that, ultimately the thought is going to reduce gradually. And step 6 is distancing or diffusion from thoughts. So they have to reduce thinking that if they move they'll get pain, if they don't move they won't have any pain. So they have to distance this thoughts from them. And grade 7 is imagery. So in step 7 we are going to use imagery, and they have to imagine, and they have to do this by practicing again and again. So ultimately practice of imagery is going to reduce their pain. Thank you.